Hello there, and welcome to this week's concept map teaching, where we're going to be giving you some hints and tips for how to approach a patient that presents with shock. My name is Liam Highland, and I'm the F2 lead rep for NUH. Just to clarify, this is not the theory teaching of shock, which we're going to present to you today, and we're not going to go through the details of each pathophysiology, which you can actually get from any standard textbook. This is more to help with the sharing of symptoms in order to diagnose patients in your approach to assessing them through presenting with shock. So the first step that we take in the approach to a patient that presents with shock is to actually categorize the differential diagnosis. We can list the differential diagnosis according to the surgical filter or via the pathophysiology of shock. We tend to prefer to differentiate it via its mechanism, hence breaking down shock into either preload, pump, or afterload. I'd just like to stress, do feel free to pause this video at any point in time and take a moment to process the information if needs be. So the different categories of shock can be broken down even further. And then within each of those further broken down categories, there are actual causes for why a patient may go into shock. So within the hypervolemic section, common causes include blood loss for any sort of reason. So this can be from a GI bleed, trauma, or AAA rupture, diarrhea or vomiting, high output stoma, or an inadequate oral intake. Moving over to the cardiogenic shock category, this can be broken down even further, going by the basis of the anatomy of the heart. So myocardial causes can include ventricular failure, myocardial ischemia, myocardial infarct, conductivity problems in relation to medications or toxins, myocarditis, and cardiomyopathy. Endocardial causes can include acute valvulopathies, especially seen in infective endocarditis, aortic root dissection, and papillary muscle rupture. Epicardial type causes can be due to acute tamponade and/or constricted pericarditis. And it's worth bearing in mind that either one of these presentations can cause both pump failure and obstructive venous return. So how do we actually go about determining the cause of shock? When we look at distributive shock, we can see that it's caused by excessive vasodilatation and impaired distribution of blood flow. So from a clinical standpoint, they have warm and pink skin, and you can see a wide pulse pressure on observation. Whereas in other forms of shock, as soon as the body realizes that it's got a reduced venous supply, compensatory mechanisms can kick into effect. And this occurs as a direct result of sympathetic stimulation or stimulation of the sympathetic nervous system. This causes vasoconstriction to occur, and they tend to have a narrow pulse pressure. So when we look at the common causes of distributive shock, we need to try and narrow them down even further. So septic shock usually develops gradually over a period of time. And this is in comparison to anaphylactic and neurogenic shock, which can present with a sudden onset. So as the septic shocked patient may have a high temperature and signs and symptoms of a potential source of infection. 80% of anaphylactic shock patients have an urticarial rash and develop some degree of respiratory distress, whether that be in the form of wheezing or sometimes a stridor. When we move on to the category of neurogenic shock, it's important to remember that this is caused by the disruption of the sympathetic nervous system outflow that occurs as a result of spinal injury above the level of T6. They have a loss of vasomotor tone and sympathetic innervation to the heart. It's the lack of the sympathetic activity that results in a generalized vasodilatation and patients presenting with bradycardia. So it differs from other forms of shock because neurogenic shock will tend to present with bradycardia and hypotension. They also tend to have a degree of trauma in their presenting history. And certain patients are susceptible to this form of shock, especially those who are susceptible to spontaneous cervical vertebral subluxation. And these patients include those with rheumatoid arthritis, Down syndrome, and ankylosing spondylitis. So when we do talk about neurogenic shock, it's also vitally important that we also mention spinal shock. Spinal shock refers to flaccidity, i.e. the loss of muscle tone, and loss of reflexes that occurs immediately after a spinal cord injury. After a period of time, spasticity ensues. So spinal shock occurs in phases from 1 through to 4. And they tend to be temporarily distributed over a period of weeks to months. Whereas neurogenic shock tends to have more of a sudden onset that requires immediate and/or urgent management. It's important to mention that most forms of shock you would initially treat with IV fluids. Different forms of shock can either respond to fluids or have no response to fluids. But it's important to look out for whether the patient who is in shock gets worse after the administration of IV fluids, because this may point towards a cardiogenic type shock, where patients can get more short of breath and increased JVP, as well as other signs of fluid overload. So if your patient does get worse after an administration of IV fluids, you must always bear in mind that they could be in cardiogenic shock. And this can be seen in patients, especially those with a cardiac history, ongoing chest pain, third heart sounds auscultated, or a murmur or sensory cyanosis seen. It's important to remember as well that shock is a peri-arrest stage, and that early recognition of the shocked patient is very important in order to prevent a cardiac arrest from ensuing. A fall in blood pressure will only take place when no further compensation is possible. So it's our role and our responsibility as expert clinicians to actually identify and treat the shocked patient in a timely manner using an A to E approach. Sometimes multiple processes do go on at once. For example, neurogenic and hypovolemic shock could happen at the same time in a patient that presents from a trauma. So please do be careful and always double check to identify and pick up any life-threatening causes that they may have. Just to round up this presentation then, I'd say that the aims of designing these particular resources in relation to the concept maps are that they're here to help differentiate common clinical symptoms. They're here to also give ideas for possibly developing concept maps of your own, to use them as revision tools and/or guides, for them to help with you applying the basic medical sciences into a clinical context, and for developing the skills of clinical reasoning. It's important to mention that they're not just here for you to memorize them, but to help with your differentiation of ongoing learning. Okay, thank you very much for listening to this presentation.